Good afternoon, everyone. Thank you so much for joining us today. My name is Megan Collette, and I am a behavioral health consultant with OPEN, the Overdose Prevention Engagement Network, and we welcome you to today's webinar, Standardized SUD Screening in Acute Care. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your answer, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work CE, and McBack credit for today's webinar. We will have a slide up with information about obtaining these credits during the Q&A portion of our webinar. We will also be emailing the continuing education credit information after our webinar today. The Overdose Prevention Engagement Network, or OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative, evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders and complex pain, and who can also answer questions both at the individual treatment level and technical assistance questions. We offer expert-led education and training sessions, and many of our webinars, like the one today, offer free CME, CEU, and/or McBack credits for our prescribers. And also, our credits qualify for the DEA required SUD treatment trainings. We provide MOUD trainings for providers as well. And this year, we are excited to announce we are incentivizing primary care providers and APPs with a $250 incentive to complete one of our MOUD trainings. We hope this encourages confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. OPEN also provides tangible tools to reduce harms of opioids and substance use, and our hope is to disseminate resources to places that need it the most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable educational materials for both patients and providers. Patient education materials can also be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options, and we assist groups all across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants, and we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. We also offer overdose rescue support, and we fund implementation of naloxone vending machine and distribution boxes, and also offer naloxone administration trainings. And these trainings are offered in person or virtual and are free. OPEN understands that effectively addressing OUD and other substance use disorders requires deep collaboration and tailored solutions to meet the unique needs of each part of our state. We continue to provide regionally dedicated behavioral health consultants, and each work directly with physicians, physician groups, and community organizations in that area to help build connections and networks locally. I would now like to take a moment to introduce our speaker for today. Dr. Mark Bickett is the co-director of the Overdose Prevention Engagement Network, whose mission is to improve lives and reduce harms from substance use. and is a healthcare leader at the University of Michigan. Prior to Michigan, Dr. Bickett was the director of the Pain Medicine Fellowship Program at the Johns Hopkins University School of Medicine and was the director of Quality and Safety for Pain at the Johns Hopkins Hospital. Dr. Bickett has been recognized as a National Academy of Medicine committee member and speaker, an advisor to federal and state initiatives, and a leader of hospital system programs on opioids. He has received many awards for academic research on pain and is a principal investigator and collaborator on several studies. He holds an MD and a PhD from Johns Hopkins. Thank you, Dr. Bickett, for being with us today. And with that, I will turn it over to you.
Great, thank you so much. There we go. It's a pleasure to be here with the group today to speak about standardized SUD screening in acute care. And as you mentioned, my name is Mark Bickett, one of the co-directors with Open. As part of our work with Open, we do receive support from Blue Cross Blue Shield of Michigan, though that won't be directly relevant to the topics we'll talk about today about screening. And we also include here our standard information for individuals obtaining continuing educational credit regarding financial relationships with ineligible companies. All right, today, just to review what will be coming forward with our discussion over the next session. First, we'll start by describing the importance of universal screening for risk of substance abuse disorder and how we can approach that using a standardized tool, why that might be reasonable to consider, and some of the benefits and pros and cons of different tools that are out there. After that, we'll focus on demonstrating appropriate ways to screen patients for the risk of substance use disorders in order to really mitigate negative impacts, notably which include stigma, but also other barriers to patient participation as well as clinician evaluation of those results. And then finally, we'll turn our attention to concluding the talk by outlining ways to help connect patients who have demonstrated risk or may just be at risk of substance use disorders to treatment. We'll obviously provide some recommendations specific to practice environments in the state of Michigan, but also recommendations more broadly as well. So first, we want to turn to the question of how common are substance use and related disorders. And we'll start by turning to answer this question for the general population before we look more closely at acute care settings like surgery. So here are some highlights from the 2022 National Survey on Drug Use and Health, which is a fairly reliable nationwide survey to help categorize behaviors among persons as they relate to not just substance use and risk of substance use, but mental health and other conditions as well. So data from 2022 reveal that about 48.7 million persons who are 12 years or older had a substance use disorder in the past year. That translates to just a bit more than 1 in 6, or 17% of persons. When we break that down by age and look at substance use disorders, we see that the percentage of people who are 12 years or older who have a substance use disorder was the highest among young adults who are of age 18 to 25. And that's just a bit more than 1 in 4 persons, at about 9.7 million people total in the United States. This is followed by adults who are 26 years or older. Again, roughly that 1 in 6 number, or just a little bit more than 16%, about 37 million people. And then a smaller proportion who are adolescents aged 12 to 17. And while this number is smaller for the adolescent population, we do need to remember that these ages of 12 to 17 and the years that come after are certainly critical when it comes to setting the trajectories for life experience later on. it comes to brain development and other factors that have implications such that while this number may be lower, it's nonetheless very important. So turning to some specific substances, we'll start by looking at tobacco use. And here's a headline from an Associated Press article noting that US adult cigarette smoking rates are nearing all-time lows, which is some good news among looking at substance use risks in the United States. The current rate is about 11% of the population who regularly use tobacco. And this represents a relative change from years before of a decline of about 12%. I think we can certainly celebrate some of that news, but it's also important to note that rates of vaping do continue to climb, and that this is certainly an area in which there's considerable growth. So while the rate of vaping overall among the population is perhaps lower than standard tobacco use at 6%, here we're seeing growths that are double digits and increases over the past year in terms of individuals who report vaping of increases of 25%, so up in that domain. When it comes to alcohol use, no surprise here that the vast majority of adults report drinking alcohol certainly at some point in time in their lifetime. And I don't think we would consider this to be necessarily a problem in and of itself. It does help to inform some statistics about the proportion of adults who do report binge drinking. And here, 22% of US adults will endorse behaviors that are aligned with binge drinking, where individuals have either 4 alcoholic beverages or 5, depending on their gender. So there are gender-specific definitions for binge drinking over a set period of time. And again, nearly a quarter of adults who meet that definition over this past year. And then finally, we think about other forms of drug use besides tobacco and alcohol. And here we see higher rates for cannabis use. Many states have recreational as well as medical cannabis programs. Here, cannabis use in about 1 in 5 persons in the United States. And other drug use such as opioids, which is particularly relevant for the acute care setting, where individuals may be considered to receive controlled substances like opioid prescriptions, of just a little bit more than 3% of the population. This includes both, the misuse of prescription opioids, which may be in the ranges of about 9 million individuals, as well as individuals who may have a diagnosis of opioid use disorder. Estimates from the survey data that we're speaking about today are about 2.1 million persons, though there's been some analysts and estimates that would actually increase this number and think it may actually rest in the 5 million to 6 million figure for persons in the United States. Based on these data and based on available evidence that is collected across clinician encounters, there's an organization called the U.S. Preventive Services Task Force, or USPSTF. And they work to improve the health of people nationwide by making evidence-based recommendations on effective ways to prevent disease, as well as to prolong life. And so in June of 2020, this task force issued new recommendations regarding screening about asking questions about unhealthy drug use in adults who are 18 years or older. And they upgraded the evidence to this B grade, saying that screening should be implemented when we have services for the accurate diagnosis, effective treatment, and appropriate care that can be offered or referred out. So they may not have to be just in that clinical encounter where a clinician interacts with the patient. But here we're talking about screening, and screening referring to asking questions about unhealthy drug use, not necessarily testing biological specimens, like doing your urine tests or hair tests or drug tests or things like that. And so I think that really sets the stage for one of the motivations for bringing screening to acute care encounters. Think surgical care, think emergency medicine care, perhaps even dental care, where while screening may be implemented more in a primary care audience, it may represent a bit of a stretch for some provider groups to think about incorporating this into the acute care setting. So here we've just integrated what we reviewed on the past slides about how often unhealthy substance use is occurring among the general population. So we mentioned tobacco use around 11%, this binge alcohol use, which we define as the at-risk alcohol as 22%, non-prescription drug use, a lot of this is cannabis at 19%, and then prescription drug misuse, thinking of opioids primarily here, around 3%. And as we look towards the acute care settings, one question relates to how often are these behaviors translated into patients that we see in acute care? And so one sample among others for acute care are patients who come in for surgery. And so Ann Fernandez and a group in 2022 that I also contributed to helped to examine and unpack this question by looking at how often adults who come in for elective surgery endorse using these substances in their time prior to surgery. And so based on surveys of individuals at the University of Michigan, we had a slightly higher than the general population report of persons who endorse tobacco use, around 14%. While binge alcohol use before surgery in the acute care setting was slightly lower, it was similarly on par. We saw non-prescription drug use to be at similar or slightly higher rates, and just a little bit higher rate at 4.5% for endorsement of prescription drug misuse among the population. So it's certainly not a stretch to say that the prevalence that we're seeing of substance use in the general population mirrors, in many cases, that of persons who come into acute care settings and have their care, specifically surgery here, but likely in the emergency department or other settings as well. And so when we look at individuals' risk profiles, not just among these specific categories of tobacco, alcohol, other drugs, opioids, but we look at them all together, and we look at individuals who demonstrated at least one risk category among those that we mentioned before. We see that roughly 2 in 5 patients here in Michigan, and in particular before surgery, present with this risky use of substances. So that's 40% roughly of patients coming in are endorsing this, and this is before, again, surgery that people know about, planned encounters regarding their health. Now, one question may come up and say, well, that's great to know that this is impacting the lives of individuals who, may be living their lives before they come in to have surgery. Are there other implications of the fact that people use substances that may be risky before, say they have this known surgical encounter? And here we outline some of the impacts of risky substance use as it relates to surgery, and there may be similar ways that these outcomes could apply to other acute care settings. So here we see a table that lists different drugs or substances. And in one column, we show whether individuals are more likely to take prescription opioids before they come in for surgery, and whether they're more likely to fill prescription opioids after surgery. Now, these are 2 fairly broad measures of individuals who come in for surgery, though they indicate that patients who come in and have a surgical procedure who are anticipated to have pain afterwards are more likely to have more complex pain management needs, both during surgery as well as after surgery as well. And across the board, whether it's tobacco use that's risky, alcohol use that's risky, opioids or other drugs, we see in several different studies that are out there that these persons who report a risk of at least one risk category are more likely to both take prescription opioids before surgery as well as fill them afterwards. And so they are certainly at risk of having challenging control of their pain after surgery, and a little different than individuals who may not be on opioids before surgery, or persons who may not need to fill them for their pain afterwards. Another way of looking at how does the risk of substance use impact persons who come in for elective surgery is to look at different outcomes for these groups after their surgical encounters. And so here again, Ann Fernandez has helped shed some light for 30-day outcomes among persons who come in and have surgery. And this is data, again, specific to the state of Michigan, though a fairly broad proportion of cases who've had general surgical procedures, abdominal procedures like having their gallbladder out, hysterectomy, or having other commonly done procedures. So both men and women, all age groups that are adults. And here we look at these different drugs or substances as they may impact 30-day outcomes for emergency department visits, for surgical complications, for readmissions, and for reoperations. And so when it comes to seeing this across the board, we see these different drugs or substances impacting at least one and often multiple domains when it comes to people's recovery after surgery and some of these adverse events that we would not want patients to experience. And of note, we see what happens when individuals may have more than one risk among types of use. So, for example, individuals who just use tobacco or alcohol at a risky level, right, differ from a profile of someone who may be using both tobacco and alcohol, where we see across all four of these outcomes increases in the rates that these happen when we compare them to persons who do not have evidence of risky substance use. So I would note, here the discussion and the data are mentioning about risky substance use, and this is falling short of a formal diagnosis of a use disorder. But for an acute care setting, right, we may not just be as concerned about formally diagnosing as it is about just uncovering risk profiles that are there. This data becomes certainly more impactful once we consider that every year we have about 123 million surgical procedures that happen. And so we have many instances in the surgical community to potentially intervene among persons who may be at risk for different types of substances. And I think the analogy also stands for individuals who may come in for other acute care settings, such as in the emergency department. Maybe individuals who come in and have, dental procedures that are invasive that may have significant pain afterwards, and similar settings such as that. Right, now that we've taken the time to review how common substance use risk is and risky substance use is, and as it relates to surgery as one example of an acute care setting, we're going to turn to think about using standardized screening tools and why that might be helpful or appropriate. Stepping back for a moment, one question that comes up is, how can we identify at-risk patients? And one traditional way that this is often done is through clinical encounters in which clinicians will review elements of the history of the physical examination and come up with a plan. And as part of that, typically the elements as they relate to someone's risk of substance use are contained within what's called the social history. And so examples of individual social history often don't necessarily receive significant attention when individuals come in to acute care settings. Here are some examples that we've seen and documented in charts, whether it's the University of Michigan or other places, for what individuals document. One is just kind of a default of none. And here one question is, was a social history obtained, or is it just that there's actually none there? Or non-contributory is perhaps not as descriptive as understanding kind of how the conversation about a social history may have gone. Or a social history that relates to alcohol use that just mentions, okay, they drink a few times per month, but still a little bit unclear. Are we meeting a threshold here for concerning behavior? Is that behavior that puts someone at risk or not? Not quite sure. And then also the kind of cousin to non-contributory denies. So someone who just says, no social history of note here. So we contrast that with some of the issues that come up, of which I've mentioned a little bit, and that's that many times reporting in the social history just isn't as complete or doesn't have the precision or accuracy that we would need for it to accurately convey someone's actual behaviors and the risk associated there. There's variation in terms of questions of how individuals are approached by their clinicians and the answers that they would provide. And then there can be some variation in thresholds from risk, assuming that we have information that could contribute to our understanding there. Many times, and this is reported both in qualitative literature and our conversations with clinicians, people will use kind of their gut feeling, the overall gestalt, or kind of what generalizations that they may make, perhaps based on their clinical judgment, but based on other things about whether someone's at risk or not. There can be a tendency to focus on tobacco, given the pack year history is often taught and emphasized in medical schools, and is a little bit easier to calculate compared to someone's standard alcohol intake or exposure to other substances. And there can be other barriers that come up where patients don't want to disclose because of a fear about stigma, perhaps inequalities in care that may come through in this domain, and perhaps concerns that as a patient, if items are mentioned about risks, that care may be denied or deferred, or have some problem that's not dealt with in an empathic and empathetic way to help them. We did spend some time speaking both with patients and providers about their experiences when it comes to screening for risky substance use. So here are some provider perspectives from a study by Hines that was published in 2022. And we detail a few different perspectives here. First, starting out with the perspective of the anesthesia provider. So, we really need to hardwire a standardized screening and pain management protocol. We need guardrails in place that make it impossible to do the wrong thing. So mentioning here how easy it is to not necessarily help the patient get connected with the right care or identify risk in that way. From primary care providers who have patients who go through the acute care setting. If I have someone who has chronic pain, says the quote, I'm thinking more about how I'm going to manage pain than the procedure they may have. So this is context of before someone has surgery. Hopefully, so they need less opioids after. I don't think about my preparatory role in any way there. So not necessarily on the radar for the clinician who's interacting with the patient before surgery. And then hear from a member of the surgical team, some systematic way that people were screened that didn't rely on busy surgeons, that may or may not think about it. Then I think that definitely would be helpful. And so, again, while these focus on surgery, I would say our interviews with individuals in emergency room settings bear out a similar theme here about the fact that clinicians are busy, that taking time out to do this does feel like a burden to certain individuals, and that there is a need to look at pathways related to this. And that is echoed, again, not just for surgery, but also in emergency department care and likely other acute care settings as well, where thoughts about the long-term impacts on patients may not be as at the forefront of minds compared to addressing their immediate needs. Here, it's also really important for us to acknowledge the impact of stigma, which we've mentioned before, but certainly want to emphasize here a perspective nationally by our current U.S. Surgeon General, Vivek Murthy. He mentions regarding stigma, for far too many people, the stigma around addiction prevents them from stepping forward for help. And we certainly want to have this at the front of our perspectives as we think about helping to connect patients to care that would be helpful, both to improve their outcomes in acute care settings, as well as improve their livelihood and their health outside of the context of those brief interactions that are there. One way to help address stigma is by being aware of the language that we use, and the fact that the words that we use when speaking with patients, speaking with family members in our community, make a big difference. And so certainly within our organization, we acknowledge that there are words and phrases that are person-centered that help to make that difference, and are one way that you as a clinician and that we as communities can help move forward and advance in terms of addressing stigma. And so words that we want to help emphasize and use talk about these conditions as chronic diseases, and in a fairly person-centered and neutral way, that persons have opioid use disorder, that other disorders, are substance use disorders, that tests are negative or positive, that someone may have opioid misuse or substance use, and it's a patient or person with these conditions who's in recovery or recovering. In contrast to words that are not as person-centric and often connote some type of judgment or have other associations with them. In particular, if test results are clean or dirty, this is not person-centric language. Thinking about persons who are, a former or reformed addict. Now, we certainly do work with communities in which persons who are in recovery may use this language to describe their experiences. And that's not to negate their perspectives in that way. But as clinicians who interact with persons who are in these communities, we are creating the most welcome environment by emphasizing the words that we know that matter the most and that are appropriate and person-centered that way. We also want to offer up some stigma-related resources. And so one part is by an addiction language guide that if you want to learn more about that, this is a resource on the open website that is available for your use, dissemination, teachings, and sharing with communities to help emphasize exactly what we're speaking about. There's also a video that I would encourage you to view about how words matter, sharing a personal experience from someone with lived experience about the impact of stigma. There's also Shine a Light with Stigma pledge that you could help your organization engage with. Our organization through Open has certainly partnered and engaged with that pledge there. And then just a plug for a later seminar that's happening in October, where there will be persons with lived experience sharing their perspectives in a session led by Dr. Pooja Lagasetti that's coming down this fall. So the importance of screening for opioid and risky substance use can lead, I think, to several helpful outcomes in the process of trying to identify persons at risk in a bit more standardized way. And one way is that, in particular for individuals who have pain, it's an opportunity to help tailor pain management strategies and start a conversation such that if individuals know that as substance use may put them at risk for different outcomes, this has the potential to help impact how they approach their pain medicine, the use of non-opioid alternatives, and helping to tailor and make sure persons have an appropriate experience. If we're unaware of the use of certain substances, depending on the context of clinical care, we may not be able to manage pain as well. It's also helpful to help coordinate care and help plug individuals in. It's important to note, and we'll speak about it later on, about the roles that acute care clinicians play and what's certainly possible and within the scope of the busy practice environment that many acute care clinicians operate in versus other team members that we want to help the patient connect with and go that way. That involves certainly communication among the team, but there are ways to help streamline that, to help do that efficiently. And so today we really want to get into those resources that would help ensure those clinical encounters really make the most of their time in that way. And then finally, this is largely a part that's missing in many acute care settings in a robust way. And so that certainly underscores one of the gaps that we're trying to address here through our discussion today. Now that we've understood a bit about some of the reasons that there may be gaps and why we want to use standardized tools to help with screening for risk of substance use, one question comes into how do we actually go about implementing some of these standardized tools that are out there? And how does one do that if they're interested in pursuing that? There are several examples of questionnaires and tools that help to screen for a risk of substance use or risky behaviors related to substances. And here we've pulled out about 4 examples. And so as you're considering the practice environment, it's helpful to understand the different domains that these tools may cover and different characteristics that may be helpful there. So here, one example is the screening to brief intervention that covers all 3 domains of tobacco, alcohol, and drugs. Most of these screening tools are meant to be efficient, so have somewhere between 3 to 7 questions, depending on responses to this S2BI. It often focuses on marijuana as a drug, so may be appropriate for populations in which that is certainly seen as a common use substance that's used. and was initially developed at Boston Children's Hospital, so certainly has a focus that involves non-adult populations as well. TAPS, the tobacco, alcohol, prescription medication, and other substance use tool, again, covers all three domains, has 4 questions. And there's an optional risk assessment that's part of that. If in the event you want to do a bit more detailed dive into someone's risk of substance use, that could be done there. And it does include non-prescription drug use, which isn't the case for other tools. The audit C is the Alcohol Use Disorders Identification Questionnaire, concise version. So it is only specific to alcohol, but 3 questions, and is one that there's been a number of investigations, in particular in the Veterans Health Administration surgical population, about its use in acute care, efficiently identifying individuals at risk, and it's linked to acute care outcomes that way. And then finally, the brief screener for tobacco, alcohol, and other drugs. This one, again, covers all 3 domains, asks about people's frequency of tobacco, alcohol, and cannabis use. And so, again, these are some options to consider starting with that are there. What do these questions look like? Well, for the BSTAT, or brief screener for tobacco, alcohol, and other drugs, typically these are focusing on use in the past year and asking about on how many days did you smoke cigarettes or use other tobacco products. So again, here trying to present in fairly neutral language about how use patterns look. And as an example of how, after going through the different categories and looking at the responses, whether it's 0 days, 1 day, or 2 or more, depending on the category, individuals, or depending on the use patterns, people will then have their results fall into one of these risk categories. If there's no reported use, people are at lower risk or higher risk, and then information being able to be used to guide conversations from there. I contrast that with the tobacco, alcohol, prescription medication, and other substance use TAPS tool that often starts out with kind of 4 questions that are in the similar vein. In the past 12 months, how often have you used tobacco or any other nicotine delivered products? This one includes e-cigarettes, vaping, or chewing tobacco. And you may recall from some of our initial slides the rise in vaping. And one reason why this question may capture a different group than perhaps the previous question from the BSTAT that may not emphasize vaping as much. And then responses options here among these 5, daily or almost daily, weekly, monthly, less than monthly, or never. And so just a bit more about the TAPS. So that's one domain with the tobacco question. There's also a question on alcohol, other drugs, as well as non-prescription medication use like opioids. And so if individuals answer affirmatively to these questions, there are follow-up questions that can go into a larger assessment, this part 2, that then can help translate individuals into risk scores that are there. Based on these different TAPS categories, it will dive into not just tobacco and alcohol, but in a larger assessment can highlight different use based on cannabis, stimulants, heroin, sedatives, others. And here's an example of a scoring rubric based on some data from primary care that we would anticipate would be applicable to acute care settings for individuals coming in. TAPS can be considered an element within a NIDA quick screen, where again we see these different levels of risk and have different responses based on someone's risk and risk scores there, right? And one approach in terms of helping with this is kind of the 4 A's model, where there's medical advice related to the risk that's given. We examine whether a patient's ready to change. That assessment assists to help plug them in to a level, and then arrange for that referral, treatment, or next steps as necessary. And that certainly could be modified for acute care settings. Note that these screening tools can be programmed into the health record. And so here's an example of some work that we've done where the TAPS tool has been plugged in. While it says, Margaret Punch, here's a fictitious patient, from 2021 who's again fielding these questions about the TAPS. And these are questions, 12-month questions here with that start with the screening, and then a question down here related to the assessment that you can see as one example to help push these out such that, perhaps for at least surgical care, someone's not doing this in the surgical encounter itself. How well do patients accept screening when they come in to acute care settings? You can imagine some people might say, well, I'm here to talk to my doctor about surgery. Why are these questions, coming through? Well, in a publication in Pain Medicine by Dr. Akbar, we found, a high, nearly all patients who were participating found the pathway acceptable to their care. There, can be some individuals who feel uncomfortable with some of the questions, even posed in this neutral format. And we did find through this survey with patients that many persons preferred actually a non-face-to-face interaction when they were answering questions about their substance use, which then would be used in clinical encounters to have conversations in person. And that finding has certainly been emphasized in primary care settings as well, where many times people will do these screening questions in one venue before they transition to the clinical encounter that has a more face-to-face aspect to it, where the results are discussed in that way. So again, if you're thinking about implementing this in your practice, there's a benefit to having that non-face-to-face portion to it. Again, what's underlying some of the thought about including these standardized tools in the health record? Well, we have existing studies that compare clinician versus the performance when the screening tools used. Here's some data as it relates to alcohol screening and using the audit tool. And here we see rates that clinicians identified patients who are at risk of alcohol use in the period before surgery. And we're seeing an overall rate right around that 6 or 7%, a little bit higher proportion of clinicians who identify this in men compared to women or female patients that they see. We compare this with the risk rates that audit identifies, and we can see, across the board, increases in the detection of rates. And so I think that's one takeaway when we look at this data, that, certainly these blue audit bars are higher in terms of identifying persons who would otherwise go undetected. And, across all patients, we're almost seeing more than double the rate of persons who are detected. It's also important to note here this difference in men and women, that while essentially, the rate goes from about 11% up to 18 to 19% for men, what this tool really helps to identify are a portion or the proportion of women who would otherwise go undetected. And so a bit of a gender gap here in terms of what a clinician's preference or what a clinician's tool would do compared to the standardized tool. We see the same thing happen when it comes to looking at using the TAPS tool to look at different categories beyond just alcohol risk. So here was results from a study that we performed looking at how standardized screening ends up outperforming usual care documentation. And the standardized tool was able to detect more patients at risk both from tobacco use. So tobacco use wasn't appearing to be accurately documented even after a preoperative visit by patients coming in for elective surgery. Here, almost none of the alcohol documentation was able to help us identify at-risk patients compared to the TAPS tool. And then this similarly with other types of drug use that were out there. In essence, one of the bottom lines here is that, 70% of the patients screened positive by TAPS were missed by this routine EMR documentation. And so when we think about screening in acute care settings and in surgery, I think we certainly want to help draw a parallel here that, patients coming in for surgery, certainly, if somebody's coming in with a condition that's well aware among the surgical community that may impact outcomes, how is that handled? So an example for diabetes, certainly surgeons will have available perhaps an A1C number or their blood sugar numbers. And if they're not in control, often there could be a discussion about how that may impact someone's wound healing or their care after surgery. And having other team members besides the surgical team involved to help manage that and help get that improved before surgery, right, certainly would be the ideal situation. I think when we think about translating that to substance use risk screening, it's similar, where use of these risk assessment tools would be able to efficiently do that. That helps inform these discussions about perioperative risks, and certainly involving primary care or addiction medicine, others as appropriate, would be the appropriate next steps to take. And this could also be applied for other acute care settings. We've taken some time to help outline what these steps look like, and in particular before surgery. So here, Victor Lin helped share a bit of a model that we had before surgery, where a couple weeks before clinic, people could receive those electronic health record pushouts through the TAPS questionnaire. This could be evaluated for people who are coming in for their preoperative evaluation visit. And then for results that were concerning, these could be shared back to the team to pursue next steps as they see appropriate to help inform their surgical care. This was a model that we looked at in terms of examining both how patients experienced the screening process, as well as how surgeons thought of it as well. And here we saw, when we looked and talked to most surgeons about this, most of them appear to accept the screening process before surgery. And that certainly was without much education or formal, program announcement in terms of how these results would come out. A lot of it was kind of coming into their queue and then getting some messages about at-risk patients. And so here, we see typically we'd want to see larger areas of blue with the agree or completely agree about, screening for risky substance use needs my approval, screening and standardized questions. It seems implementable and realistic for the care settings that are there. And so part of this surgeon acceptance was, and one way I think that we try to approach it is breaking up the steps and really identifying what a plan needs to look like for patients who come into this area. There are ways to split up what the responsibilities of an acute care team would be versus care from others that are out there. So one, potential flow that we've considered is where the substance use screening happens. There's a sharing of this risk once patients are identified, education and a brief discussion of how it could impact their care and what the main team leader for their care, whether it's a surgeon, emergency room clinician, or others think needs to happen, and then making appropriate care modifications, whether it's surgical care for perioperative care or others. And we can also think of other things that may exist outside of the acute care team, whether it's referrals, resources, or links to care. And one way that we try to help share a perspective is that this risk identification really serves as a bridge or a link for patients in acute care to these different types of programs that may be out there. And while different areas of the state of Michigan and different health systems may not have one or all of these, that there are certainly different ways that care could be modified for these patients, plugging into different programs, seeing addiction services. Maybe there are unique pain management needs that individuals have. Perhaps it's a patient who is at risk of withdrawal that we need to help with. And so from our standpoint, our organization has helped to develop some standardized elements when it comes to communicating the results from screening to help guide this. This has been informed by input from the certainly surgical community and other acute care clinicians, and the screening experiences that I have shared before, in which there are roughly these 3 to 4 steps that would be involved. And one is, certainly to confirm the findings of the screening tool that the patient filled out, express concern using empathy, create a plan that's tailored to the patient and their care. And sometimes that plan may just be acknowledging the risk, and that is the extent of it. And sometimes the plan may be some of those other next steps that we mentioned on that prior slide. And then finally, educating and advising the patients about what to do. And so while this text here is a little bit smaller, just know that there are examples where these plans are fleshed out that are available to you as a resource. And it comes through this substance use disorder screening and care coordination toolkit, in which, again, available here on the website to download, for each of the different domains, and in particular for the domains on the TAPS questionnaire, but these could be used for risk domains identified on the BSTAT or other screening tools. Some examples of steps that certainly include resources specific to the state of Michigan, but also other generalized resources and steps that would be appropriate even for patients who reside outside the state as well. I do want to come to a note here just to say that our organization does offer expert consultation services. And so you certainly had mentioned, this had been mentioned at the start prior to this session's beginning, but we have same-day consultation services available, and those do exist as a resource for the acute care community as well. This is not just for primary care. Monday through Friday, 9 to 5 right now, and experts in addiction medicine who can help guide, whether it's understanding what to do with screening results, prescribers managing these patients who have substance use disorders, complex pain needs. And consults may be initiated online. Here's a link. It's also on the website where you can submit a consultation. So when we're thinking about next steps here, certainly would want to encourage you to consider how both in your clinical practice as well as within your health system, we think about screening individuals for risky substance use in acute care settings. The types of communication that can happen between patients and their caregivers with the clinical teams, and then working to coordinate care across these groups as some of the most important elements that are there. Appreciate your time today and looking forward to engaging with you here, as well as having the opportunity to continue to offer programs and services through the Overdose Prevention Engagement Network. Thank you for your time.
Thank you so much, Dr. Beckett, for all the information you've shared today and for being with us and taking time to give us all of this great information. Before we start with questions today, I would love for you to take a moment to draw attention to your screen and notice the continuing education credit information that's there. You can either use your smartphone and scan those QR codes, or you can access this information in the following email that we will send regarding CE credits and obtaining all of this information through that pathway as well. So we will leave that up here for everyone to use and scan. And then if there are any other questions and answers for or questions for Dr. Beckett, please go ahead and throw those in the Q&A function down at the bottom of your screen, and we'll get started making sure that we have Dr. Beckett answer those for us. And Dr. Beckett, one of our questions for you today is, I work with youth in a residential treatment setting. Are these screening tools as effective for ages 12 to 17 years old?
Great question. When we think about applying screening to individuals who are younger than 18, a few issues come up. One is that there is a separate recommendation from the task force that I had mentioned before, this USPSTF group, regarding a recommendation about screening for risky use behaviors for substances among persons who are less than 18 years of age. Here, the recommendation from that national organization has been that there's insufficient evidence at a national level to recommend the screening or use of screening tools for that age population. Some of it relates to the fact that the number of studies that have been done specific to that age group have been less in number. They just haven't had the evidence base for them. That's been the case in contrast to having evidence that screening for that specific group has led to negative outcomes or experiences. And I would just reiterate that the data we're talking about is largely for a primary care setting. So the USPSTF often looks at, for example, primary care setting as opposed to acute care that we're talking about today. Now, that being said, for acute care settings, and when we would consider the impact of risky substance use on surgical outcomes, while the population that's less than 18 certainly undergoes different types of procedures compared to those who are adults, I would certainly be pressed to think that the results of these outcomes that are often worse among individuals who screen positive would differ in large ways for that group. And so while the evidence is not sufficient, we certainly would hypothesize and expect that among persons who demonstrate risk, that they would have increased risk of adverse outcomes for different acute care counters, and for surgery, that those 30-day outcomes, like we said. We do want to certainly make sure and emphasize these challenges about stigma, about other barriers that come up, are certainly present as well, and do need to be navigated with appropriate, again, empathy, as well as the additional element for persons who are under 18 of communicating not just, with the patient here, but also their caregiver as well. And so that represents another important dynamic that would need to be under consideration when thinking about screening in that group.
Great, thank you. Next, we have, what are the issues around SUD and complex pain management?
Great. It's a great question thinking about this intersection for persons who may have substance use disorders, as well as pain management needs that are kind of beyond the ordinary, whether they're in acute care settings or chronic care settings. One thing that comes up is often that trying to help individuals obtain treatment may end up having an impact and may be relevant to their acute care and in the acute care setting. Examples of this come up pretty regularly, especially for persons who are taking medications to treat opioid use disorder. So, for example, buprenorphine is available by prescription for anyone, any clinician who has a license from the DEA. The requirement for specialized training went away at the start of 2024. And we've seen rates of prescribing of buprenorphine increase slowly, but somewhat in 2024 based on some recent data that was published in the New England Journal of Medicine about 2 weeks ago. Buprenorphine, as many of you may know, certainly binds very tightly to opioid receptors and works in a special way to occupy the receptor. It activates it a little bit, but not as much as other opioids, but it also impairs other opioids from binding to it. And the long story short is that that has implications in pain care for these individuals, especially if they undergo, major types of surgery that are going to require significant times for recovery and pain profiles there. There are other examples in which medications for opioid use disorder, such as methadone or others, have similarly interesting ways in which they interact with individuals' pain pathways and systems that do need to be taken into account when designing pain plans for patients. All that to be said, I think in general for communities of patients who need access to these medications, that we'd much rather have individuals get plugged in and receive these types of treatment, in particular in advance of surgery, and then navigate some of these complex issues, as opposed to have them just go through without that type of support. And that's really just an answer that focuses primarily on the medication management, but there are other important elements that come into play. For example, if individuals already have a peer support network for some of their recovery, it's certainly important to engage them and make sure that they have an identified plan about how those support networks can come into play. And if they don't already have that, that be a consideration to be established. So I do think there are some very specific instances in which their care does need to be tailored and is more complex, and it's appropriate to recognize those. And doing the screening is certainly one way for us to help identify persons who may benefit from that additional communication, care coordination, and thinking about a plan for them. Thanks for that question.
Great, thank you. And looking at our time to be together today, we'll have time for our last question. We have community health workers who are going to focus on providing resources and referrals to clients with SUD. Could these screeners be used in this type of setting?
Great. So the screening tools certainly are designed for having patients respond to describe their experiences over the past 12 months, 3 months, depending on that. So really, anytime you're having interactions with patients in which there's the opportunity to help provide them with a link to resources and help get their assessment of these questions, in theory, these questions could be used to help part of that process. Now, it's important to note that screening for just the sake of doing the screening questions itself, right, is not necessarily the best use of a patient's time. If we're unable to then help link them to the resources or at least provide some way in which this would impact their care, the time and the expense and potential downsides of this screening aren't necessarily going to be there relative to other situations where we're going to be able to help in some type of follow-up situation, help patients understand, what their results are, how this may be relevant to their care setting, whether it's an acute care setting or otherwise, and take active steps after that. So great opportunity and great question there. Thanks.
Great. Well, once again, I would just love to say thank you to all of our participants today for joining our webinar. Please do take a moment to check out our website for future events. The link is also in the chat for your convenience. A huge thank you to you, Dr. Beckett, for being with us today. And we hope that you all have a wonderful rest of your Friday and a great weekend. Thank you all so much for being here.